Hello, everybody. Welcome to our second session of this packed virtual patient safety congress. We're going to go straight into this one now and looking at reimagining care through digital transformation to build a smarter and unified NHS. And of course, I'll be looking for lots of question and discussion from you, the audience, so do get involved. But we've got today joining us, we've got Dr. John Payne, consultant transplant cardiologist and clinical safety advisor in Scotland from InterSystems, and Dr. Paul Leonard, an ED physician and eHealth clinical lead for NHS Lothian. John, over to you.
Thanks, Sean. Thank you. I will share my screen and then we'll get going. Okay, so you can see that, Sean. Give me a nod. Yeah, okay, great. Thanks for that introduction. So this is what I'm going to talk to you about today. I'm going to talk briefly about what I think digital transformation is and talk about the electronic health record, which is the digital workhorse, if you like. Then I'm going to talk about what some of the benefits. There are many benefits to going digital, but I'll talk about some of the benefits, but also what are the risks associated with going digital. There's lots and lots of benefits of going digital, but I think the point I'd like to get across in this talk is that there are risks associated with it, and healthcare organisations need to be mindful of that. We'll then talk about Track Care, which is an electronic health record produced by InterSystems and is widely used in Scotland. And we'll talk about how Scotland has adapted much in the same way that many other healthcare organisations have throughout the world, but adapted in a digital way. So we'll talk about some of the examples of the changes that we've made to Track Care. And then finally, we'll talk about some of the ongoing work that's going on in the digital arena with Track Care in Scotland. So I'm a transplant cardiologist. I work in the transplant unit in Glasgow, which covers Scotland, and I've been doing that since 2010. And in 2010, I inherited a lot of patient safety and quality work. And lucky for me, I found it really interesting and became very passionate about it. And that led me to do a fellowship in patient safety and quality under the umbrella of the Scottish Patient Safety Programme. So that was in 2013. And since then, I've had an interest and passion in learning and improvement, and have had a role in governance and learning from errors and getting better, basically. I also work for InterSystems. So about 4 years ago, they approached me to work for them. And that was an opportunity I thought I couldn't refuse, given that fundamentally digitization is about introducing new systems. And so I work as a clinical safety advisor for InterSystems. So I work in the NHS, I work in governance, I have an interest in quality improvement and safety, and I work for a vendor of a digital product, in this case, Track Care. So this is something that inspired me a lot, and I felt as though I couldn't not put it up, because if you haven't read this book and you're interested in quality improvement and learning from mistakes and safety, then this is a book that's well worth reading. And I can see from the audience, people who've registered, that there's a big, there are lots of people in the audience who basically have a role in governance. So this is a great book. And really it's basically the history of quality improvement over the last 30 years in healthcare. And there is a chapter in that book, regarding the role of the electronic health record in healthcare. And there's a quote which I've paraphrased here, which actually, I'm just going to minimize this because it's getting in my way, so I can see my own slides. And the quote is that the single most effective way to improve safety and quality in healthcare is to implement an electronic record. And that came from a leader in healthcare, George Halverson. And I thought that was quite a sweeping statement and quite a powerful thing to say, and made me think, you know, this person who's very credible really believes this. And it left them, I always remembered this quote. And when InterSystems came to me a few years later asking me to work for them, to work for a vendor of electronic health record, then For me, it was a no-brainer to get involved in that. So what is digital transformation? I've got a couple of definitions there, but I'm not going to focus on those so much as talk about what I think it is. So, we all know that going digital is often a simplistic way of thinking about it. Is you're losing paper, you're going paperless, you're getting rid of your paper and you're putting it onto a computer. And there's no doubt there are benefits to that, and paper has its costs, but there are greater benefits. There are much bigger benefits than that, and we'll talk about those in a minute. And I think that's what makes it transformative rather than just a photocopying of paper onto a computer. It gives you an opportunity to change the way you do things and to cut out a lot of waste. And so it's that kind of transformation which I think it truly is transformative, I think, and I think hopefully you'll see that as I go through the talk today. So the digital workhorse for healthcare is the electronic health record, and it's defined as a longitudinal electronic record of patient health information, and it includes a lot of information. So anything really you want to put into it, you can do. So progress notes, problems, diagnosis, medications, reports, laboratory data, everything in one place. And so what are the benefits of digital transformation? And so I could do a 2-hour presentation on this and still not be finished with the benefits of digital transformation. But I think for me, the most important benefit is it's what the patient wants, it's what the customer wants. And for me, what defines quality is what the customer wants. And I think that's the most important part of going digital. Fundamentally, if you're going digital, you're doing what the customer, the patient wants. And I've asked a lot of my patients about going digital and going electronic. And not only do they expect hospitals to be electronic and digital, they actually think it's already happened. They think that 100% of hospitals are 100% paperless and are using computer systems, when clearly for most hospitals that's not the case. Well, why wouldn't they expect that though? They do their online banking, if they book a flight, it's done paperlessly. If they go to a supermarket now, they don't pay in cash. You have contactless, and even contactless has moved on now to paying with your phone. So everything's going digital. So the expectation of the patient and the customer is that healthcare is digital. In some ways, healthcare is kind of behind the curve, really, if you look at the other industries in the world. So some of the classical benefits of going digital are getting rid of paper, as I said before. And paper costs. It costs money to buy it, it costs money to print it, it costs money to move it, to store it. And when it gets lost, there's a cost there as well. But with a digital record, it's much more easily accessible. So you can access that record from a different hospital, can access it from home. The record is always there. It doesn't get lost. And then another kind of classical sort of benefit is the elimination of poor penmanship. What a great phrase. What they're really saying there is that doctors' handwriting is particularly poor, and it's easier to read. When something's typed out, you can read it. When something's handwritten, it's easy to make mistakes. So some of the more sophisticated kind of benefits of digitization is clinical decision support. And there are lots of examples of that. And perhaps one of the best examples is looking at drug interactions. We know there are thousands of drugs that we can prescribe, and many of them interact with each other to cause potential complications in patients. We can't remember all those things, but computers can, and can help you to basically avoid potentially dangerous interactions. You can use computer systems to order things, so laboratory tests, radiology tests, and you can measure those tests and what the demand is for those tests. So another benefit. And then you can have a health information exchange where you're pulling in information from lots of different places. So from different hospitals, from different care providers, from social work, for example, so outside of healthcare. So you end up knowing more about that patient, knowing whether that child is on a vulnerable register, things like that, which are really important when a patient comes into an emergency department. I like, again, this list it goes on and on and on and on. But for me, the kind of generic sort of benefits are the increase in transparency. So I believe transparency improves quality and improves safety. And the electronic health record improves transparency because you can access, it's much more easy to access the information. But it's also easier to measure as well. And so measurement, we know, is the foundation of improvement. And with computer systems, measuring becomes so much easier and can be done on a much more regular basis than compared to if you're using paper. And then finally, we know that standardization is really important in healthcare and in improvement. And digital systems help that and encourage that to happen. Most digital systems will only accept one way of doing something, or 2 or 3 if you're lucky. So if you think about discharging a patient, rather than having 50 different ways to discharge a patient, like one of our customers a few years ago, it forces them to think about what is our standard process for discharging a patient, because we need to standardize if we're going to use this system. So there are benefits of using an electronic health record and going digital, but there are also potential pitfalls, and it can introduce risk. The bigger your digital footprint, the more you're dependent on your digital system. And there's risk associated with that. And that's what I want to get across on this slide. So if you think about devices that we use in healthcare, such as pacemakers, such as pulse oximeters, thousands of devices we use in hospitals. And this is a highly regulated area. You think about the delivery of healthcare in the form of checklists, the World Health Organization surgical checklist, ward round checklist, lots of processes we now have in place that are scrutinized by clinical governance departments. So lots of scrutiny, highly regulated. You think about health safety in the environment. If somebody mops the floor, that floor is wet and somebody can slip on it. So you leave a caution, a sign with caution wet floor is left so that somebody realizes to walk around it. And then finally, perhaps the most regulated area of healthcare is drugs and medications. And so there's an awareness that all these areas of healthcare can potentially harm somebody or harm a patient. So what about digital systems? And in my experience and the experience of my colleagues in the NHS and in InterSystems, this is a corner of safety that really hasn't been looked at in the greatest detail in the UK and around the world. And that's not to say there aren't some amazing exemplars of management of risk with digital systems. But in our experience, we're behind the curve on this. Digital systems can harm patients. There are many examples of that. A simple one would be if there's a bug in the system, in a prescribing system, you prescribe a drug and there's a bug in the system that doubles the dose of that drug. So if a patient gets double a dose of paracetamol or an antibiotic, they're unlikely to come to much harm. But what if that were a chemotherapy drug whereby you double the dose and actually could potentially harm the patient or kill them? And there are lots of examples of that in the literature of patients coming to harm because of those problems. What if a follow-up appointment for a breast cancer screening or breast cancer treatment follow-up appointment doesn't come through because of a bug in the system? So again, patients can come to harm because of that. So moving on from safety, TrackCare, I'd like to tell you a little bit about the system that we use in Scotland that's produced by InterSystems called TrackCare. So TrackCare is effectively an electronic health record or a unified health record. And it's used in secondary care and used in hospitals throughout Scotland. It covers 97% of the population of Scotland. So it's used widely by most of the health boards in Scotland. And it's an organisation-wide system. So several of our customers in Scotland have over 10 hospitals in their organisation. All those hospitals would be on one installation of TrackCare. And all the different types of user would use TrackCare. So secretaries would use TrackCare to book patients into the system. Doctors would use it, nurses would use it, managers would use it to pull data out for reports. So it's an organization enterprise system. And it has a global footprint. So it's used in 27 different countries in over 450 hospitals. So I mentioned to you about safety with digital systems earlier, and this is what we're doing in InterSystems to make sure that our product is safe. So we have a clinical safety management system, and that system is built around the guidance of the English standards, which were produced by NHS Digital a few years ago. They recognized the potential for digital systems to harm patients and produced a set of guidelines, one for the makers of digital systems like InterSystems, and one for the users of digital systems such as the NHS. And so we have a global clinical safety team, which you can see in the picture, and our system, or clinical safety management system, is really broken into two bits. A proactive part of the system, which is when we make changes to TrackCare, we look to think, is that safe? Is there anything in the way we've designed that could harm a patient or make somebody make a mistake? But we also are interested in when something does happen that could potentially harm a patient or has harmed a patient, much in the same way that Datex works in healthcare. And so we call that's the reactive part of our safety system. We also produce a hazard log for TrackCare, we produce a clinical safety case, and we produce product safety alerts and safety reports for our customers. So moving on from safety in digital systems, I'd like to talk to you a bit about the response that, digital response in some ways, that have been made in Scotland, using TrackCare as an example. Simple changes that certainly won't be unique to Scotland, and certainly we're not suggesting that Scotland's response to COVID has been any better than anywhere else. There's been some amazing examples around the world of healthcare organisations adapting to COVID, and this is just an example of it. So we were lucky enough in Scotland to already have a group that managed changes or requested changes to TrackCare. And that group allowed us to hit the ground running when COVID hit a few months ago. So customers, the NHS health boards, came to us asking for changes that needed to be done quickly. And that group allowed us to basically vet those changes and get some of the other customers, some of the other health boards, to sense check the requested changes and adjust them and refine them before we made changes to TrackCare. So we had a dedicated full-time coordinator running that group, and they met very frequently initially. And we kind of worked in an agile way, in the sense that a change would be made, we'd show it back to the customer. If they liked it, then we would deliver it. So a kind of iterative cycle of change, if you like, a PDSA, plan, do, study, act sort of methodology. And this is one of the first changes that we were asked to make. So we were asked to produce a COVID alert and a COVID status icon. So these icons were attached to patients' names when they were seen on TrackCare. So a green icon was associated with somebody who'd had a test that was negative, a red for a test that was positive, and a purple for a test, the result of which was awaited. And this was requested throughout Scotland, so it was a regional request. And it allowed the users, clinicians, to be able to see on floor plans where the high-risk patients were, and helped plan the use of beds and the management of patients. It was used by some, but not all of the hospitals, and I think Paul might tell us a bit more about that at the end. And this is what it looked like in TrackCare. So this is a screenshot of TrackCare of an emergency department floor plan. And you can see that one of the patients, Belle McLaughlin, has got a red icon, which suggesting that she's had a positive test for COVID. And then there are green icons for the other patients. So similarly, we were asked to produce a shielding status alert for similar reasons, so that the hospitals could recognize which patients were high risk and who had shielding status. And the Scottish government were very quick to gather together a list of all the patients that were considered to be high risk. And they delivered that list to the health boards in Scotland and asked InterSystems to produce a technical way of transferring those data into each track care installation. And so that is what happened. And on a weekly basis, that list was updated. And sometimes the list wasn't absolutely correct, and a clinician had the ability to edit that alert, so to downgrade somebody's status or upgrade them to a shielding status. And that's what that shielding status icon looks like on the track care floor plan. And then finally, again, sticking with icons and alerts, there was a requirement to know who was intubated or who was ventilated. And we all know, going back a few months, the concerns about having enough ventilation equipment. And so we know that there was plans to ventilate people outside of intensive care units. And so there was a requirement to know who was ventilated, who was intubated, who was getting non-invasive ventilation, and to have that data at the fingertips of the managers and the people who are allocating resources towards. And so these icons were produced with associated alerts. So moving away from icons and the like to the hospitals that were built in response to COVID. So we're all familiar with NHS Nightingale hospitals in England, and Scotland had effectively an NHS Nightingale hospital, which was named NHS Louisa Jordan. That was built in an exhibition centre in Glasgow and had over 1,000 beds. And similar to the Nightingale hospitals, as well as having a kind of quite amazing physical build, which was done very quickly, they also needed, perhaps less well known, a digital build. And NHS Louisa Jordan was no different. So the expectation was that patients who came into that hospital would have some information associated with them that could be looked at electronically. We weren't just relying on the relatives or the patients to tell us what allergies the patients had, what was their past medical history, etc. And so a digital build was done by NHS Greater Glasgow and Clyde very rapidly with some help from InterSystems. And similarly, one of the NHS Nightingale hospitals had a digital build built by InterSystems very rapidly. Going further afield, not just in the UK, track care is a global product and is used in 27 different countries, and including Italy. And so Gemelli Hospital in Rome had to build its own COVID hospital. They named that hospital Columbus COVID 2, and that was a smaller hospital than the ones that we'd seen in the UK. And so they did a digital build for that with InterSystems in 7 days. And they also converted a hotel into a post-acute care facility. And again, there needed to be a digital build for that, which was done with InterSystems. Finally, thinking about COVID testing, again, required a digital framework or network, if you like, so that all the COVID testing data could be pulled together. In the UAE, we helped support the building of a network that linked together 118 labs, and we did that in 14 days. So on perhaps a brighter note, there's all this talk about a vaccine this week, and undoubtedly this is going to be a big challenge. It seems that we're struggling to be able to deliver the flu vaccination currently, and we hope to deliver a COVID vaccination for perhaps most of the population in the UK. And there will be a physical challenge there, but there will also be, I think, a digital challenge to allow patients to book into their COVID vaccination, but also to know who's had a vaccination, who hasn't, and any contraindications they may have to vaccination, which will be held on their medical record. So undoubtedly, there will be a digital build, and I suspect the InterSystems will be involved in helping helping the NHS to build a digital solution for this challenge coming ahead. So moving away from COVID into some more long-term projects that have been ongoing during this time and predates the COVID problem is a user interface. So you just saw earlier a few screenshots of the old TrackCare user interface, which is still used by many of our customers. But we've realized for some time, having listened to our customers and listened to the users, that that interface is looking dated, it's quite busy, it has a lot of colors in it, and can be quite complex to use. And so we've invested a lot of resources into improving that user interface, making it simpler, making it more modern looking, and reducing the use of color. I believe, and I think I'm not unique in this belief, that the user interface has a big impact on how safe the system is, much in the same way that a dashboard that's easy to use allows people to fly planes and drive cars more effectively. I think the user interface is important in keeping TrackCare safe. And so this is another contributor to the safety of the product, but also it makes users more likely to use a digital system such as TrackCare. So it's really important for us and our customers that we push this forward. With that new user interface, we're also building in the ability for that for TrackCare to be viewed on devices that have different sizes. So, for example, an iPhone, an Android phone, or a tablet. And so the screen will resize itself. We've all seen that in lots of other technologies, and we are all familiar with the notion that you have a desktop screen and you have a mobile screen. We're applying those principles to TrackCare to make it be able for the user to use this in a mobile way and in a touchscreen way, and in so doing that, making it possible to access TrackCare virtually rather than doing it through a fixed desktop. So on that kind of moving on from that, thinking about mobiles, some of you will be familiar with the Apple Health Records. So Apple thought that it would be a good idea for patients to be able to view their records, which makes complete sense to many people, I think. And I think it's a good example of transparency improving quality by making the health record more transparent and more accessible to patients, and more empowering patients to get more involved in their health, in the management of their conditions. And so Apple have made it technically possible to view a health record from their device. And so InterSystems through TrackCare have worked very hard to make it technically possible for Apple Health Records to access medical data in TrackCare. So all of our customers in the UK who are on the latest version of TrackCare have the ability now to access for patients to access their records through TrackCare, and so so technically that is possible. So we're working with our customers to hopefully bring that to fruition in the future, so that we will have some customers in the future who will have patients that will be able to access their medical records through TrackCare. So in summary, digital transformation in healthcare, I think, improves quality and safety, but it also can introduce risk. And I think what I wanted to get across in this talk is that I think there's a great opportunity to improve safety and improve quality by being aware that digital systems, as well as giving many benefits, can actually introduce risk and can actually harm patients. And an awareness of this can allow organisations and the NHS to manage that risk, much in the same way they manage risk in other parts of their business. Digital systems such as TrackCare can be responsive, and we're giving a few examples of many of TrackCare doing that response to COVID. But I think there's also many things to be excited about in the digital area in healthcare. Thank you for your time. I think, Sean, you're muted.
That's the second time I've done that today. I need to, you'd think I'd be good at this, wouldn't you, by now? Thank you for that, John. I appreciate your talk, and there's lots for us to get into there. But Paul, if I could bring you in here as a customer of this service, but also obviously as someone who's been working through the last few months. Just talk us through your thoughts on this and the digital landscape as it is, but also obviously the innovations in recent months.
Yes, so I'm an emergency medicine consultant. I've been working with the InterSystems Track Care product for about 18 years when we first put it into the emergency department. And just as John was talking, I was just reminding myself what healthcare looked like at that point in time, with everything written on pieces of paper and bits of notes needing to be shuffled around, and how whilst John was talking, I was electronically signing off results from one of my other sites, sitting at my desk in a different hospital, and it being a very sort of different place. COVID, of course, as everybody knows, has brought us a huge number of challenges, and in Lothian, we've helped address a good number of these through the digital system. So you saw the icons that John showed you to help identify patients who are COVID positive or query COVID, and they've been useful in some of our emergency departments where they've let people use the clinical space flexibly. So there was an initial, we've got to have a red zone and an amber zone and a green zone. We've got to split all of these patients apart, and then a sudden realization that actually if you've got a limited space, then balancing those multiple patient flows can be very difficult. So actually having flexible space and the ability to clearly identify patients who are COVID positive or query COVID has been very helpful. We've used a lot of the scheduling systems to enable us to start a move towards scheduling unscheduled care. We have used Track Care as part of our sort of ecosystem. So we're using the video consultation stuff to provide virtual minor injuries assessments, reducing the number of patients coming to the emergency departments, and also allowing us to distribute the workload between the EDs. So rather than patients just necessarily turn up to the nearest ED, start to think about moving them to one that's got slightly more capacity, perhaps, and can see them faster. We used some of the InterSystems functionality to build some advanced care planning, again, sort of visible across all our sites, icons visible on the floor plans so that we can see what decisions patients have made about their healthcare, perhaps the last time they were in, if they arrive at a different site. So yeah, quite a lot of stuff.
Paul, I suppose if we turn to the questions from the audience now, and I'm really pleased to see that people are piling in with their thoughts. And there's a slightly pejorative question here, which I want to sort of put to you both, see what you think about it. And I might just align it with another one as well. But there's a question here, anonymous. NASA relies on 10-year-old tech to avoid breakdowns that risk lives. Why should the NHS rush to innovate if we already have something that works? And there's another question around how do we address the challenge of staff who are not computer savvy? And I think those two actually in some ways go together. So I just wonder what you would say in response to that.
I'll let Paul answer that, if that's all right, because I've got a kind of conflict of interest with working for a vendor. I think it has more credibility coming from Paul. Go on then, Paul. He's volunteered you. Let's hear it.
So I suppose why should we innovate? I don't think we do have systems that work. I think we know that with paper systems, that yes, they have a lot of advantages, but they don't always work. Results go missing, for example. You're seeing a patient in one hospital who was in a hospital a few weeks ago with some chest pain. You're looking at their ECG. You're trying to decide whether or not they're having an acute myocardial infarction. If you have an electronic ECG archive that you can drop into and look at from the other site, then you can see that their ECG hasn't changed, or it has changed, and you can get them the appropriate treatment. So I think the innovation is driven because the systems we had weren't working. In terms of how do you deal with the technologically unsavvy, I think that is a challenge. When we first put Track Care into our emergency department, the lead consultant didn't know how to double click with a mouse. So the way you've got to address that is by showing them that it can do something for them. It's got to make their life better in some way, and then helping educate them. So a lot of training and people who are championing the systems, I think, is the way forward for that.
There's an interesting question here from Zoe Brummel. Thank you, Zoe, for this. It was something I was thinking of as well. Is there measurable correlation between hospitals with EHRs and measures of patient safety, for example, CQC ratings?
Yes, there is, and it's a correlation, and I think that is, I think the HIMSS, if you're familiar with HIMSS, they're a group who basically look at digital maturity in healthcare organizations around the world, and they have shown quite nicely, at least a correlation between your level of maturity and several measures of quality and safety. There's another argument that the wealthy organizations can afford very sophisticated systems that are digitally mature, and that's why they're safe. But fundamentally, there is a correlation. Proving causation, as we know, can be quite challenging, and that's a different question altogether.
John, I don't know if you can answer this question. I'm not sure I quite understand it myself, but I'm going to ask you just to see what your answer is. But it's what about the role of CSO assessments and DCB 0129 and DCB 0160? Does that ring any bells with you?
Yes, it's a good question. So basically, I mean, that's kind of close to my heart. So DCB 0129 and 0160 are digital, are kind of standards of how to manage risk in digital systems in healthcare. And they were produced in England, and they've become a global set of standards that have been taken on by lots of different countries because they seem to be so good. And they're a great foundation to, so one of them is for the vendors, such as InSystems, and one of them is for the implementers, if you like. That would be the NHS here, or private hospitals who use digital systems. And it's a good framework basically to manage risk for digital systems, and it's one that we want all our customers to be aligning themselves to. Remind me what your question was, Sean.
Well, they were asking effectively, what about their role of CSO assessments and those two DCB?
Yeah, I think CSO, I think fundamentally it's a system. It's not reliant on, it's a system. And I think it's about, if you look at other industries that have high risk, such as construction, aviation, space, everything really has risk attached, and they've all got pretty sophisticated clinical safety management systems. And if you look at healthcare, there's very few of the hospitals that I've worked in and seen actually are doing that sort of work. I think they're just behind. I think it's just there's a lag between something coming in and then the realization that it needs to be managed. It's just a normal kind of development process almost.
You're both clinicians, and obviously we're a safety congress, and there are two questions here from Helena and Diane, which both raise really interesting issues. And I've come across this myself as a health journalist. And the question effectively is, do some digitization risk de-skilling staff, causing them to over-rely on it rather than on skills of observation, conversation, and experience? And Diane adds that she completely agrees with that. And she says this was demonstrated by incidents where staff reliance on the new National Early Warning Scoring system had a negative effect. I suppose we're talking about sort of care by computer and protocol, and is there, does that come with risks? And I'd be interested in your reflections on that, both of you.
Paul, I don't want to hog the kind of steam.
I think there is a risk there. Yes, absolutely. If clinicians are spending their whole time just typing data into computers and relying on the decision support within them, then they do lose that sort of clinical savviness that's required. But I think you can use these systems to augment that clinical savviness. So if you allow a combination of gut feel and clinical skill, plus the computer delivering the clinical scores, the drug interactions that John talked about, then I think you end up with a better hybrid system than either completely digital or not digital at all.
There's plenty of questions coming in, more than I can possibly keep up with. So apologies if I don't get to every question, and we're going to have to finish in a few minutes. But there's a question here that I'll just pull out around, will we ever get to a sort of UK electronic system? Interface issues are so frustrating. And I suppose we're talking there about how systems talk to and connect with each other. And we see this all the time playing out with problems. But we also saw the disaster of the national IT system as well that cost us billions. Do you think we'll ever get to something like that? And is there a way that these different systems can plug into each other across geographical areas?
So I think the answer to that is we will get a lot better than we are at the moment. I think the challenge with having a national system is allowing something to be flexible enough at the local level to deal with the inevitable differences in local systems, local service provision. What we have in Scotland are we are able to join up and view data from other health boards through our clinical systems, and I think that that's probably going to be the first thing. Will be a much greater ability to share information. We have, for example, a Scottish National X-ray archive system, so any image taken anywhere in Scotland can be viewed from another hospital in Scotland. So I think the joining up will happen. I don't think it will be one instance of one system.
And we need to bring in other areas like social care, for example, which is something somebody's mentioned in Q&A as well. Yeah,
absolutely. And we do that in Lothian. We have a link with our social care system.
Yeah, and I suppose we're coming near to the end of the session now, so I suppose this will have to be the last question to you both. But there's a question here. While digital systems add tremendous value, it's important these systems are able to speak to each other, which we've just touched on, isn't there? And they're saying, is there examples of different systems that operate within hospitals and community care? Are you both aware of those? Or presumably track care obviously is working across most of Scotland, isn't it?
Yeah, Paul can give you, I'm sure Paul can give you some examples of that.
Yes, so we actually use track care in the community setting. We don't use it in general practice in Lothian, but our health visitors and district nurses, our child protection team that work in the community, they all put data directly into track care, and it's one of the great advantages of the system. If you're sitting at the front door, you can see, a lot about what's happening in the community just within the electronic patient record in front of you.
Well, gentlemen, I'm afraid we've got many more questions, but we'll see if we can facilitate some answers after the event. But I'm afraid we've run out of time now. But thank you very much, both of you, for joining us this morning. Clearly, by the number of questions, you've triggered lots of people's thoughts and inspiration for others, and it's been fascinating to listen to. And I'm sure we're going to see some very interesting developments in this field in the weeks, months, years ahead. So thank you very much to both of you. And for the rest of you who are joining me for the next session, which will be kicking off shortly, we're just going to have a bit of a break now. So do, as always, go to the exhibition area. Do have a look at some of the resources there where you'll find a bit more about the issues we've been talking about in this session. But if you can join me back at 11:05 for our next session, which is caring for our caregivers. Thank you very much, gentlemen, and thank you for the audience joining us.
Bye, everybody.
Bye.